In this video, I'm going to discuss the mechanism through which the neurons, pacemaker, and ventricles undergo depolarization and repolarization, and then discuss the mechanism of action of different anti-arrhythmic medications. So neurons will undergo depolarization by the influx of the sodium, and then later on they would undergo repolarization by the efflux of the potassium. Now during the first phase, when there is a sodium channel influx, due to the closure of the sodium channels, there won't be any more action potential, and this is referred to as absolute refractory period, during which time you cannot have another action potential. And then the phase where there is a potassium efflux is referred to as relative refractory period, where greater than normal stimulus is required in order to produce the action potential, and the reason for that is that the potassium conductance is higher than the normal resting conductance. And then we have the pacemakers, which are responsible for the automaticity of the heartbeats, and this is being done via the IF sodium channel, which has an upward slope that causes the depolarization of the pacemakers. So the steeper this curve is, the faster the heart rate, and the less steeper it is, the slower the heart rate. So therefore the steepness of the sodium channel, IFNA channel, determines the heart rate via the pacemakers. So once there is a certain level of threshold that is being met, the calcium channel will be open, the calcium will influx, causes depolarization, and then later on potassium channel will cause repolarization. So this first phase, IFNA, is referred to as phase 4, the calcium influx is phase 0, and then the potassium efflux is phase 3. And then for the ventricles, we have phase 4, phase 0, phase 1, phase 2, phase 3, and then finally phase 4. So once there is a depolarization, sodium will influx, and then during phase 1 there is the efflux of the potassium, which will cause repolarization, and during phase 2 there is some influx of calcium, which will cancel out the potassium, so therefore we are reaching a plateau. And then later on the slow potassium channels will open up, and at the same time the calcium channel will close up, and that would lead to the rapid repolarization of the ventricles. Now the other term I would like you to know is that the period from phase 0 to phase 3 is referred to as effective refractory period, and it's because during this period not any new action potential can be occurring, and this property will prevent arrhythmia of the ventricles. So just keep that in mind. Phase 0, 1, 2, and 3, during this period it's referred to as effective refractory period because no new action potential can be produced. Okay, so now that we've discussed the mechanism of action potential in the ventricles, now we can discuss the mechanism of action of different antiarrhythmic medications. So class 1 antiarrhythmics are acting on the sodium channels. Class 2 is a beta blocker. Class 3 inhibits the potassium channels, and then class 4 is a calcium channel blocker. So examples of class 1A include the quinidine, procainamide, as well as the disopyramide. And then by effects here, I would like you to tell me how these medications affect the action potential duration. And so class 1A causes increased action potential duration, and I will tell you a memory aid that would make it easy to memorize all these names as well as the effects on the action potential for class A antiarrhythmics. So just forget about memorizing them for now. I'll provide you with a memory aid and then you can try memorizing them after that. So with class B, which also acts on the sodium channels, and then it shortens phase 3. And then I should have mentioned that class 1A slows phase 0 in the His and Purkinje fibers. So examples of class 1B include lidocaine, mexiletine, as well as tocainide. And so the effects of these medications on the action potential is that they decrease the duration of action potential by shortening the phase 3. And then the class C medications again slows the phase 0 in the His and Purkinje fibers, and these medications include the flecainide as well as propafenone. propafenone. And these medications have normal action potential. So unlike the other ones which affect the duration of action potential, class 1C does not affect the duration. So here I have a memory aid for you to remember the features of class 1 antiarrhythmics. So for class 1A, the names is, memorize this sentence, Queen proclaims pyramid dice. So the medications of class 1A include the quinidine, proclaims goes for prokinamide, and pyramid dice goes for disopyramid. And then class 1B, the memory aid that we have is that light Mexican tobacco. So we have lidocaine, mexilatine, as well as tokinide. And then for class 1C, the memory aids are flies can hide, and then pros phone home. So fluconide as well as propafenone are medications of class 1C. Now in terms of their effects on the action potential, here we have the black line which corresponds to the normal ventricle action potential. And then class 1C doesn't change the action potential. So class 1C is right on top of the normal action potential. So C remains constant action potential. So class 1C doesn't affect the action potential, while class 1A pushes the curve above. So class 1A pushes the curve above, so it increases the duration of action potential, while class 1B pushes the curve below, so therefore it will decrease the duration of action potential. So now here we can go through what I just discussed for you here. So class 1A pushes the curve above, so it increases the duration of action potential. Class 1B pushes the curve below, so it decreases the duration of action potential. And then class 1C keeps it constant, so no change in the action potential. And then in terms of medications for class 1B, light Mexican tobacco, so lidocaine, mexilatine, and tokinide. For class 1A, Queen proclaims pyramid dice. And then finally for class 1C, flies can hide and pros can phone home. So this way now you have the name as well as the effects on the action potential for all class 1 sodium channel blockers. And then for class 2, we have beta blockers which will decrease phase 0 in the AV node, and then they would also decrease phase 4 in the SA node. And examples of beta blockers include, for instance, metoprolol, propranolol, as well as esmolol, which is a short-acting beta blockers. And beta blockers, as well as calcium channel blockers, like for instance verapamil and diltiazem, both of these medications function by decreasing the AV node conduction. And so therefore, since they are both acting through the same mechanisms, beta blockers and calcium channel blockers both can be used for the treatment of atrial fibrillation. And then finally, we have the potassium channel blockers, which will prolong phase 3, and therefore they would increase the action potential duration. And examples of class 3 antiarrhythmics include, for instance, amiodarone, ibutilide, dofetilide, as well as sotalol. And then one last point I would like to mention is that sotalol is also a beta blocker, so sotalol belongs to both class 3 and class 2, and then amiodarone belongs to class 3 as well as class 1A. Okay, now next I would like to go through the side effects of some of these medications. So both sotalol and quinidine can increase the risk of torsades development, and then quinidine is also associated with the synchronism, where the patients present with headaches, tinnitus, as well as vertigo. Prokinamide is associated with drug-induced SLE-like symptoms. So as a reminder, medications that can cause drug-induced lupus include the hydralazine, isoniazid, prokinamide, as well as phenytoin. And in these patients, they are positive for anti-histone antibody. So prokinamide can cause SLE-like symptoms. Next we have amiodarone, which can cause pulmonary fibrosis, hepatotoxicity, photosensitivity. They could also cause corneal deposits, as well as hypo or hyperthyroidism. So it can also affect the thyroid function. And then we have beta blockers that can have many side effects, like for instance the impotence, as well as masking of the hypoglycemia. And then calcium channel blockers like verapamil or diltiazem can cause constipation, flushing, as well as hypotension. Now, in addition to these medications that I've listed here, there are other anti-arrhythmic drugs that you should be familiar with. And these medications include, for instance, adenosine, which is a short-acting medication that is used for the treatment of supraventricular tachycardia. And so adenosine functions by decreasing the AV node conduction. And the potential side effects of adenosine that you will have to be familiar with include flushing, as well as chest pain. Magnesium is the other medications that is used for the treatment of torsades. And then digitalis is used for the treatment of atrial fibrillation. So the memory aid that I have for you is A, B, C, D. So atrial fibrillation is treated with the first line medications beta blockers, second line medications calcium channel blockers, and then the last line treatment with the digitalis. And I will discuss the mechanism of action of digitalis next. So just know that if you will have to choose between these medications, you will have to choose beta blocker first, and then calcium channel blockers, and then digitalis would be your last option. And so all of these three medications function by decreasing the AV node conduction. So next, I'd like to go over features of digitalis. So patients with digitalis can have different side effects. For instance, they can have yellow vision, nausea and vomiting, as well as arrhythmia. So here is the memory aid. You can see that the patient had vibration around it. So that goes for arrhythmia. It's throwing up, goes for nausea and vomiting. And then there is a yellow toilet, which goes for yellow vision. And so for the treatment of patients that have digitalis toxicity, you can provide them with the potassium, magnesium, as well as anti-digitalis FAB fragments to inhibit the digitalis-induced arrhythmias. And then one medication that you should absolutely avoid in these patients is quinidine, because it decreases the digitalis clearance and thus it would enhance the toxicity. So far we've discussed the adverse reactions of digitalis, the medications that can be used for the treatment of digitalis-induced arrhythmias, and the medication to avoid in patients that have digitalis toxicity. And then the final point that I would like to discuss for this video is the mechanism of action of digitalis. So digitalis increases the parasympathetic tone by acting on the vagus nerve, and so therefore via this mechanism it would decrease the AV node conduction, and thus these medications can be used for the treatment of atrial fibrillation, as I discussed earlier. So all these medications, beta blockers, calcium channel blockers, and digoxin, decrease the AV node conduction and thus can be used for the treatment of atrial fibrillation. The other mechanism through which the digitalis works is that it increases the intracellular concentration of calcium, and thus it would increase the inotropy as well as the contractility of the heart. And how digoxin works is that it inhibits the sodium-potassium pump, as a consequence of which sodium will start to accumulate inside the cell. And so therefore the sodium-calcium exchanger would no longer function because there is already too much sodium. So it won't bring any more sodium in exchange for calcium to be removed out. So since there is no more calcium that is going out, calcium will keep on accumulating inside the cells, and calcium accumulation causes elevated inotropy and increased contractility of the heart. And that concludes our discussion of the anti-arrhythmic medications.